If you had to give a young physician, someone who wanted to start their own practice, some early advice, what would you give them?
Learn the subject properly. Because unless your basics are clear, the results are not going to be great. 100%, that I believe 100%. That you need to know what you are injecting. You need to know what is there in the syringe. And to know that, you really need to go to the depth of the matter.
Really know what you're doing. Fair enough. Welcome back to another BIOS KOL Sessions podcast. Today I have a true honor and privilege to be here with Dr. Tulpule. She's on a 12-hour time change. We're here in Las Vegas. She's actually just fresh off finishing a really big conference in India. How was the trip over?
Oh, that was great. The conference was very successful, and it was for the first time in India that we had such a big conference on just regenerative medicine. And we had over 400 doctors attending the conference.
That's amazing.
Yeah.
And what if people want to find out more about this conference? What's a good place for them to look at?
So it's Regen 2025. That's the website.
That's
so www.regen25.com.
That's awesome. And obviously we're going to get into some of your micronized adipose that you just finished talking. So thank you for taking the time. But I wanted to start a little bit with your background and kind of what drew you to Orthobiologix.
So I'm an orthopedic surgeon, a very hardcore one at that, and I was only hardware surgeon, I would say, hammering and screwing and stuff. And the shift happened around, say, 7 to 8 years back when I came across Dr. William Murrell, who used to do a lot of biological work at that point, and I saw some phenomenal results on my patients. I was primarily practicing in the UAE, Dubai, at that point, and I started using biologics to start with just PRP and bone marrow, because bone marrow was the friendliest thing that I could do with the bones. And
it made you still feel like a surgeon.
Yeah, exactly. Okay, and so we just started, and I saw really, really fantastic results. So the journey started. I got trained in regenerative medicine with the American Board of Regenerative Medicine. And gradually, I just saw the shift in my patients, and more patients came and asked me about these treatments rather than undergoing surgeries. So initially, I used to do all arthroscopic surgeries and supplement it with or augment it with biologics. And then gradually it is like, full-time into Orthobiologics. We opened a regenerative center and in Mumbai, India, around 2.5 years back now. It's called Orthobiologics with an X center. And we have branches of that center now in India, 4 or 5 branches till now. And we also went into training doctors because there was no awareness of orthobiologics or regenerative treatments for MSK disorders in India. So we started doing a lot of patient-centric education as well as doctors' trainings. So we started training doctors in all these orthobiological treatments. We started doing diplomat programs, fellowship programs, and so on and so forth. So that has been the journey.
That's amazing. Actually, congratulations on all of that.
Thank you so much.
And what are the differences in maybe patient population, or what are you seeing indication-wise from one country to the other? Are you doing more PRP in one or more bone marrow in the other? What's the workhorse?
Oh, so that's a great question, I would say. There's definite difference in the patient population. Dubai is very, very multinational and multicultural, city or the region. We have 220 nationalities in Dubai. And so I pretty much treated all the nationalities from all over the world there. So the experience, expectations, the educational background, the medical awareness is very different across cultures. In India, there are, again, you go back to India and there is a lot of inflammation related disorders happening. It's already called the diabetes capital of the world. And so the root cause in there was chronic inflammation. And so patients responded very well to all these orthobiological conditions there. So population wise, yes, okay, there are different, in UAE there were more of sports related injuries. So I treated lots of sports people, football injuries, that was very common. That is very common in Dubai, and people from even Saudi and around surrounding regions, they travel there for sports injuries treatments. So basically more of sports related injuries in UAE and more of degenerative or chronic inflammation in India.
Interesting.
That's how I would say.
So you guys recently published some PRP guidelines at the Regen conference. Is that?
Oh yes, so that was the first in India and that region, the whole region. There is a lot of wrong information, wrong claims being done in media by doctors, and so there was lot of confusion going around. So we had a group of 17 leading regenerative medicine specialists and orthopedic surgeons who were practicing regenerative in India for a long time. And so we got together and we had a consensus, and we published a very detailed guideline on PRP, and we're getting it endorsed by multiple associations and bodies at the moment. And that could become a reference point for PRP, all over the world.
Where do you stand with PRP? We had a discussion this morning, and I want to get to one of the questions you've made, which is great. Do you are you on low dose, high dose? Where do you stand on how much blood to draw, how much to inject? And obviously, let's just stick to one pathology for now. Let's knee arthritis.
Yeah. So, there are two ways to do it. One is I do multiple, not so high dose, I would call, I never do low dose, okay, but it could be around 5 billion. I do 3 sessions, consecutive, 3 week apart. So this is the standard. Some patient, if the patient is traveling or he's flying from somewhere else to just get the treatment done, I would just say, okay, just take one. But if I'm just doing one, better be a very high dose, like super dose. So that would be 10 billion plus. So we don't take anything below 60 ml of blood draw. There are very strict protocols which are laid down. Otherwise, the results are not going to be the same. So, so basically 2 ways. Okay, so so that's the first choice I give, multiple dosage with a pretty high dose, like 5 billion. Otherwise, just one. If the patient cannot travel 3 times to the center, then just 1 dose, but that's a super high dose.
And what are your thoughts on leukocytes for these injections? Do you mind them? Do you try to reduce them?
I try to be leukocyte poor.
Me too.
Not always possible. We don't know actually, that last thin line. But I try to be leukocyte poor.
As best we can. Understood. What are your thoughts as an orthopedic surgeon on the intraosseous component? Obviously, I know we need more data, certainly.
Yeah.
But have you seen, is that something you've incorporated? Where do you see that going?
So I don't do intraosseous for the simple reason that all my subchondral edemas or bone edema, what we say, have responded very well to the biologics that we use. Either an adipose cell treatment or the one which we do in that region, which is gold-induced cytokine therapy. I'm going to talk on that tomorrow. So we're getting extremely good results with it, and that's the reason why we've not ventured into intraosseous. I've got complete healing of subchondral cysts, some complete healing of subchondral edema with just these intra-articular injections, and so there was no need to do that. Intra.
Fair enough. Well, can we touch a little bit on GOLDIC?
Why not?
What is it?
That's one of my favorite topics.
Great, awesome.
It's an autologous conditioned serum. It's acellular. It's very simple outpatient procedure. You just take 40 ml of blood for one joint, incubate it, and it's incubated with gold particles basically. And once it is incubated, then it is centrifuged and filtered. Once that filtered serum, that's a very highly activated serum, so that's injected into the pathological area. That contains, so what is the difference between that with all the other orthobiologics is presence or upregulation of gelsolin. Gelsolin is a protein which is actin binding protein basically, and that is upregulated almost more than 10 to 20 times.
Okay.
The importance of gelsolin was researched, it was researched long time back in 1970s, 18s, but it had been seen that it drops down when there is a rheumatoid arthritis or any autoimmune disorder or even simple osteoarthritis. And so when we upregulate it, all these chronic inflammatory or immune modulated conditions, they improve. And that's the basis of this. If you know, gold used to be used rampantly for treating gold injections for rheumatoid arthritis.
No, I didn't.
So
this is where it came from.
1984.
Till 84.
Yeah, that was the first line of treatment for rheumatoid arthritis treatment. And because of rest of the issues, because of injecting gold, it was stopped. So this treatment actually does use that property of gold, but we filter the gold out.
Got it.
Okay, so you're not injecting gold, but you're injecting just the juice of
that.
Yeah.
So what would you say the main indications for GOLDIC? Is it, could it be tendons or is it just joints?
So,
what are your indications to inject it into?
So we can do it in chronically inflamed joint or degenerative joint, but I would say the bestest indications, one is spine. Okay, we do epidural injections of this, and it gives fantastic results for degenerative spine or lumbar canal stenosis also. We get good results in degenerative disorders. Specifically, I would mention chronic Achilles tendinopathies. Gives beautiful results with this. Like we get all normal tendons within a year. MRI shows like complete reversal.
Amazing.
We also get very good results of this with autoimmune disorders. So lots of them, rheumatoid arthritis being one, but ankylosing spondylitis have treated, psoriatic arthritis, and so on and so forth. So all these are one. In osteoarthritis, I'm going to talk about it tomorrow, but now we know that osteoarthritis is not just wear and tear, and it's a chronic low-grade inflammation. Plus, it has got an immune modulated element also. Okay. So it's a systemic disorder which is manifesting in your knees as one of the symptoms. So what we postulate now is that you treat the local pathology with intra-articular, either whatever orthobiologic you have, but you need to give systemic orthobiologic also. And so GOLDIC is the only orthobiologics which has got safety studies and everything done for its IV administration. It's just a serum. So you just give that. That has given us better results.
So you combine both IV and injectable.
As well as that.
And how do you make the decision between someone to give them PRP or give them GOLDIC, or
it's
is
a very
it a
difficult decision.
One we're still working on.
But with GOLDIC, we are getting very long-term results.
Okay.
So probably that makes it easy for for patient. Sometimes patients who are really grade 4, just looking for a temporary treatment, I would definitely push for PRP.
Okay.
Plus economics drive the decisions a lot.
Yeah, of course.
Because it's gold induced, so obviously it is going to be price of gold.
Yeah. Now you made a question today during the PRP panel on are we dosing the right thing, right? We're putting such a focus on platelet dose, and your question was, well, how much does it actually really matter, or should it be more dosing about growth factors? Yeah. What inspired that question, and kind of what's your thought process on that?
So basically, we are getting very statistically driven. That's what I felt. Yeah. And we see a lot of good results even when the dose is not the dose, and even if it is subpar, not really subpar, like not very poor, but still we do get very good results. As somebody else also pointed out, okay, that you do, somebody has done 1,000 cases of PRP with acceptable results, and then suddenly they realize that, oh, I'm doing a low dose PRP. So that's what I meant by it, that there is something more to it than just the platelet dose. One is that. Second point is not all the platelets that we inject are active, live, healthy platelets. So there's almost 30% of the platelets which are old and senescent or senile.
Interesting.
Okay, so how do we calculate that? That's where the question was coming from. Another thing that, muscle injuries, we have seen excellent results with just platelet poor plasma. So what is there in platelet poor plasma, which is healing muscle injuries? Even chronic trigger points, like in dorsalgia or dorsal back pains, we get a lot of trigger points, which are very chronic and they just don't respond to anything, and we are doing treatments with PPP, platelet poor plasma, and they just respond very well. So there's something more to it. So I'm not against the dosing, but I'm just trying to see that, we need to go beyond that probably. There's something more there which we have not understood.
Sure. How do you prepare a patient? It's hard to beat the United States on inflammatory conditions and diabetes, but in having to deal with that problem, are you preparing the patient before these injections? Are you trying to drop their hemoglobin A1C before you do the injection? What's the thought process there?
So that's a great question. We always prepare the patient. There's no walk-in PRP happening in our clinic. There's no walk-in procedure. I see the patients and they actually are prepared for a month, and then we do the treatment.
Amazing.
So no, never ever that patient just comes and says they just inject me with PRP. No, that doesn't happen. We do put them all on anti-inflammatory diet. We do get the blood work done and get it all within normal limit before we even try to do this. We have an endocrinologist on the panel who sees the diabetes and treats the diabetes and gets it in below 6, and that's where we go. We have very strict protocols because it's very difficult to balance 2 countries with good results.
Sure.
So we have like strict rules, do's and don'ts, and everybody follows that. And so this is how it goes, that the consultation is done. After that, the blood work is done. Patient is put on all these diets, stopping aspirin, stopping NSAIDs and everything. And then patient is prepared and then taken for orthobiological treatment. So that's how the rules are.
The way it should be. Right? Yeah, the way it should be.
We do that.
So we've talked a bit about PRP. We talked about GOLDIC. Your lecture today was on micronized adipose. How did you start using that, and how have your results compared?
So I started using it with arthroscopies, basically. So initially, first case I remember doing was for meniscus tear, and I'd done a partial meniscectomy and pushed adipose MFAT actually, and which gave phenomenal result actually. The second, and then it started. So I started doing arthroscopic cleaning, lavage, shaving, and then doing this, and I used to get really fantastic results. One of my patients, I remember, on 7th day had come dancing in the corridor.
They were so happy. Huh?
So that's how it started. And so we use multiple systems, and right now I think the point that I made in the lecture also, that thorough washing is the key, and right sizing is the key. Unless that is there, the relief is not going to be really good. And we're getting very long-term results with MFAT as well. Average I would say is 5 years.
What's your preferred harvest site? Obviously, you started doing arthroscopically. Where are you collecting from now?
Lower abdomen.
Lower abdomen.
Yeah, I'm an orthopedic surgeon. I play very safe. I don't venture into any other territory.
Fair enough.
And if I actually need to do that, I call a plastic surgeon for sure. I'm not adventurous, in fact.
So let's say we're going to do a knee injection.
Yeah.
How much do you aspirate? What kind of lavage do you do? Is it just gravity, decanting? Is it centrifuge? And then how much do you like to inject back in?
So that's again a very good question. So right now, what the system that I'm using, I need to harvest around 50 ml of fat for one knee. Generally 70 to 80 milli for 2 knees. That's what the harvesting is.
Yeah.
We wash it thoroughly 2-3 times with ringer lactate, 100 ml of ringer lactate. So
quite
that's
a
a
bit.
very
Yeah.
thorough washing.
Yeah.
So oil, debris, RBCs, everything is removed. Then it is centrifuged and it goes through the processor, which is a micronizer. So I'm not doing just the decanting, but
Gotcha.
actual washing.
Okay.
And result, probably I always get more than 20 to 25 ml of MFAT, like final, but we do mix it with PRP as well. So we can do actually four joints in just that one processing.
Now,
Resultant one MFAT, how much? I generally inject 6.5 to 7, that range. If the knee is really small, then we reduce
it.
Yeah.
Have you seen some people report maybe some longer flares when using adipose versus bone marrow or PRP? Have you seen anything like that?
So that's again a good point. Basically, when we do multiple joints, okay, so like I have done 4 joints sometimes, like 2 shoulders and 2 knees, in an autoimmune patient, definite flare.
Yeah.
That's going to be flared.
Okay.
So we need to be, we need to prepare the patient mentally that it's not going to be just, a breeze, but you will be really having
it's a procedure.
Rough time for 3-4 days at least. But other than that, I don't think there was any issue.
Okay.
So this is when it is multiple, yes, then you do expect. But if it is just 2 knees, nothing happens.
They're going to do fine.
Yeah, they're very cool.
Now, in terms of immediately after, what's kind of your protocol? Do you like to get people into physical therapy? Do you just make them rest? Kind of what's your typical protocol for after a knee biologic injection?
So for adipose, I would be resting the patient for a while, at least 2-3 days, just to be sure that it is not flaring up. But other than that, PRP or any other biologic, we do 48 hours. We do tell them not to stress too much. They are homebound and they are icing every 2 hours. None of the patients need any painkillers. They are very comfortable. If at all it is needed, we just give simple Panadol, paracetamol tablet. And physiotherapy, always we start on day 4th to 5th day. We start the physiotherapy. We have trained physiotherapists with us who take over from there, who also have been trained in our courses.
That's awesome. So you made a great point on the size of the fat, right? Yeah. So this is micronized, it's not nano fat.
Yeah.
What's the typical size? What's your recommendation on how small do you want to make it?
So it's generally 500 to 600 microns. That is the size.
Got it.
Okay. And if you go really towards nano fat, then you lose out on the SVF and you lose out on the regenerative potential. It's more for cosmetic purposes or fat purposes rather than the regenerative purposes. And if you keep them bigger, which sometimes had happened with me in some systems, and patient is screaming then.
Really painful.
Yeah, it is very painful. So you need to be sure that the system that you're using is giving you, good proper sizing.
And in terms of pain, are you okay with using local anesthetics with your injections? Do you prefer to keep the area,
No, I do regularly use local anesthetics, but they are just for skin and subcutaneous.
Okay.
But we don't go till the capsule at all.
Got it.
Yeah.
Now, the way I've seen fat also for tendinopathies or smaller contained partial tears is as a scaffold.
Yeah.
And I like to get small amounts of adipose, process it. Sounds similar to yours, and then I inject small amounts of adipose into the void, and then follow with PRP or bone marrow. Do you see a property of adipose as a scaffold to kind of bridge the gap?
Yeah, it is definitely. I mean, it is a living scaffold that we have, and but again, just to do it only for tendon issue, I don't prefer that.
Okay.
Maybe the patient psychology in that region is not so that for a small tendon thing they'll allow us to do adipose. I don't think so. So we do a smaller procedure. So either a GOLDIC or PRP. Works very well.
Got it.
Yeah. Most of the times GOLDIC has done the job for this. chronic tendinopathies.
I did want to touch a little bit on just the business side of it. You know, I like to think of myself an entrepreneur, and obviously you've done a phenomenal job. So from a building and scaling perspective, right, when we look at the phenomenal things you've done, how do you run, you know, clinics in Dubai and Mumbai? You know, what have you found most important in creating consistency? Is there a system that you've put in place that just works, or is it two separate things?
Okay, so this is possible only because I have a great team.
Great, yeah.
Without that, it is just not possible. So team and protocols.
Yeah.
Like, it is like strictly to be followed.
Yeah.
So the same thing can be then replicated everywhere, you know. So initially what worked for us, we just started replicating it. It works that way. But yes, I think the team which is there is the most crucial part of anything like this.
Yeah,
Otherwise,
absolutely.
it's not just going to work.
And do you spend a lot of time, it sounds obviously you guys focus a lot on education and training.
Yes.
Do you take a lot of time with new hires to teach them the protocols? Kind of what's the secret sauce, right, in making that work?
So we started training because the doctors didn't know anything. At least, I mean, what we saw, that nobody is aware of these treatments, and they were just making their impressions from hearsay. And so we wanted, you know, to create a community where people are aware of these treatments and they can administer those treatments. And so we started, when I did my American Board of Regenerative Medicine, I was so sure that I'm going to do this in India one day. So that's how we started these courses. So we started initially without the American Board. We just started on our own, and we just started teaching the orthopedic surgeons or pain physicians who used to approach us. And we used to, because they were scared of doing these treatments on their own in their clinics. And so what we thought, that we just used to tell them that, hey, the patient is ours, you don't need to bother, you just come here and learn. And so that initial barrier, the fear factor, that was gone. That's how we started. Then we started a formal course of Diplomat of American Board of Regenerative Medicine. So it's a didactic course with a little bit of practical aspects included in that. And now we are starting a fellowship program, which is like proper 6 months fellowship with the theory lectures in Bombay, followed by in-person training in our center. We have a medical college in Chennai, which is affiliated with us now for these trainings. We will be including ultrasound training also in that. So it's like, all in one, a comprehensive training.
That's amazing.
Yeah.
If you had to give a young physician, someone who wanted to start their own practice, some early advice, what would you give them?
Learn the subject properly. Because unless your basics are clear, the results are not going to be great. 100%, that I believe 100%. That you need to know what you are injecting. You need to know what is there in the syringe. To know that, you really need to go to the depth of the matter.
Really know what you're doing. Fair enough. All right. Well, thank you so much for your time. We're going to do a little fun close here with some quick questions.
Okay.
All right. So if I'm a first-time visitor in Mumbai, what's the one thing I have to absolutely do or eat?
Do or eat? Eat. There's a long list. Okay, but I could just say maybe vada pav, because that's the signature dish for Mumbai. And if you want to really experience Mumbai, okay, just go on the streets and walk. Okay, it's like phenomenal city of very friendly people, and it's a very different city to experience. Something close to New York, I guess, the energy, but the people are very different.
Got it. All right, so you're in a stranded island and you have to treat the one patient that's there. Do you pick GOLDIC, PRP, bone marrow, or adipose? You could only choose one.
Okay. I think I'll go for GOLDIC.
GOLDIC.
That's very safe. It never gives flare-ups. It has got smoothest post-procedure recovery. It's like I always tell patients, it's between choosing A Honda and a BMW.
Got it. Probably gonna go with the BMW.
Yeah.
All right. Well, thank you so much. It's really been a true honor to have you. I really wish you best of luck in tomorrow's lecture and safe travels back.
Thank you so much for having me. It was a pleasure talking to you.
Absolutely.
Thank you.
All right. Hope you guys enjoyed it. Tune in for the next one. Thank you.